Okay, this next young lady, our next session will be introduced by the star of the highly acclaimed series, Run the World, and the shows Happy Together and Ghosted. Please, and I need y'all loud here, get your hands together for Miss Amber Stevens West. Come on, y'all, Amber Stevens, she's here. Yes!
And hello, hi, I'm Amber Stevens West. I'm so happy to be here and introduce our next panel. So, African Americans make up about 35% of people with kidney failure. But early treatment can avoid extreme damage to kidney function. So here to talk about patient advocacy in fighting kidney disease in African Americans, please help me welcome advocacy relations professional and founder of Links to Equity, Deanna Darlington, and board certified physician in nephrology, Dr. Vincent Anthony.
My name is Dr. Vincent Anthony. I am a board-certified internist, nephrologist, and a hypertension specialist. And I've been in practice since about 2006, after having come here from New York. Did some of my training in Philly and stuff, but I love LA. Okay, so the question was, what is kidney disease, right? So kidney disease comes in two flavors, really, to make it easy. There's acute kidney disease, which is obviously acute means it just happened. We can typically reverse a lot of acute kidney disease. Sometimes it causes scarring that leads to the second variety, which is chronic kidney disease. Now, chronic kidney disease is irreversible loss of function of the kidney. So, therefore, people a lot of times don't know that they've had any kidney disease. You know, and the reason is that kidney disease, kind of like hypertension, really doesn't have any symptoms early on. And so it becomes a huge issue.
Why is it so important in the Black community? What is the sort of impact and incidence of kidney disease? We know that there's 37 million folks in the U.S. diagnosed with kidney disease. Why is that important to the Black community?
Well, one of the main reasons it's important is because I like to say the attack rate for the African American community is a lot greater. So, for instance, for our majority population, the white population, they may have 900 per million population have kidney disease, whereas us, we will have 3,000 per million population. So it's a very impactful disease in our community.
And are there other diseases or comorbidities that exist with kidney disease that sort of perpetuate the disease? And can you talk to us about what those other diseases are and how does that really sort of perpetuate what the Black community needs?
Sure. So diabetes is the #1 cause of kidney disease in this country, followed by hypertension, which both of those diseases, 1 and 2, hit our communities fairly hard. But there are also some other rarer diseases that impact us a lot. And something called FSGS is one of them, focal segmental glomerulosclerosis. Y'all don't have to remember that, just FSGS. But it has to do with there's a primary FSGS and a secondary FSGS, like we were talking about before. And it's very important for the Black community because it is the #1 primary cause of a kidney disease that leads to dialysis need. And so we need to know a little bit about this disease.
Okay. All right, so in that rare disease, can you tell me how would I detect that? Tell me how would I detect, well, kidney it's a little tougher, but when we get to that rare FSGS, how do I detect that? How do I know if I have it?
Well, really, you would have to have your doctor look at your urine test and your blood test, all right, to determine if you have any kidney disease at all. And then there are several steps after that that you go through with your doctor that could actually diagnose FSGS, you know, and the primary way we do that is through a renal biopsy.
Okay, so a biopsy is what we're looking at. And so I would go to Dr. Vincent, and Dr. Vincent, if I'm your patient, you're going to sort of look at me over time to assess if I need this biopsy?
Correct. And one of the things that I always tell my patients is that we're going to move really quickly to see what we can reverse. And then if we can't reverse it, figure out what we can treat to slow the progression of kidney disease down. Because of that previous statistic I mentioned, more African Americans go to end-stage renal disease per million population than anyone else in the country, save a couple of small groups, Native Americans being the one, okay? So it's very important that we know what the symptoms are, okay? And so of FSGS, the primary form, which is basically swelling, is the only thing that you all will see. But it's up to your physician to measure the protein in your urine, to see what your blood pressure is doing, to look at the cholesterol pattern that you might have before making that decision to go further with a kidney biopsy or other testing to actually see if you have this entity or not.
Okay, so let's talk about interventions a little bit. We know that there's probably some pharmacological interventions, but I would think that there's also some things that we can do lifestyle-wise to support us from ending up in that end-stage renal kidney disease space. So what can you talk to us a little bit about those interventions?
Absolutely. The biggest intervention is obviously exercise and diet. The kidney is a ball of blood vessels, basically. Okay, it's specialized blood vessels that do a myriad of things in the body, but it's so connected to the heart, excuse me, that I tell people anything you're doing to protect the heart, you're actually doing to help the kidney. Now, there are some other things you can do to help the kidney along a little bit more, and one of those things is antioxidants. Antioxidants actually work at the one of the kidney structure levels to actually improve the function of that particular small structure and keep that small structure from being damaged so much. And it's called the glomerulus, but if you guys just remember it as a filter, that's what filters the blood, gives you your urine, and lets good stuff go on to the rest of the body, okay? So it's important that we have those kinds of dietary changes. And the exercise does the same thing. The exercise itself helps lower the cholesterol, helps lower the blood sugar, and allows us to utilize blood sugar better in the system.
Okay. So when thinking about our physicians, how do we identify a physician that is going to sort of identify and monitor what we're doing from a lifestyle standpoint, testing the different types of pharmacological interventions? What should we look for in a physician to help us? Because we know that everyone is not spectacular like you are. So what should we look for in our physician? And if they're not doing something, what should we do?
Well, first and foremost, you need a physician that talks to you. I think that I've told people before that the word doctor in Latin means to teach. It has nothing to do with being a physician. So if you don't have a physician that's talking to you and giving you an education on what's going on with you, I think that's not a good fit. You need to try to find somebody else. Secondly, you need a doctor who will answer your questions, right? Because if you have a doctor that's put off by somebody asking them a question, you have a doctor that's put off by your health and by your body. So you don't want to be in a situation with that particular person. So I always tell my own family, look for those two things. Can you ask a question, and can you actually talk to them and have them talk to you in a way that you understand what is going on with you, and above and beyond that, in the community, we could be doing some things to engage the physicians in the community. There are groups like blackdoctorusa.com that actually has a list of African American physicians on it. Black Doctor List here in California has that same thing. But for me, it's making sure the community understands what we can do as a collective to modify how doctors treat us and how then they answer our questions. And that leads me to you, is I'm very interested in what you do.
Sure.
I'm very interested in policy and advocacy. Links to Equity is somebody that you're representing here today, as well as the Rare Disease Diversity Coalition. And so with those two organizations, I know I'm kind of turning the tables here, but I'm curious.
I'm excited.
What do those organizations represent, and how do we actually get involved with them?
Sure. So thank you for that question. So Links to Equity represents a consulting firm that I am the president and CEO of. And I've been in industry and the healthcare system for about 30 years. And what I noticed in my sort of tenure in healthcare is that there's a lot of information out there, but I don't think that really hits the community. And I noticed that some of the same groups were the same groups that were educating their membership, having access, having funding, but not really at a community level. And if we're going to change the way our healthcare system, because let's be very clear, our healthcare system is not built for us. So we have to modify our behavior and the broader healthcare ecosystem behavior to accommodate that.
Right.
So I strongly believe that we need to work much more closely at a community level, work much more closely with groups like Black Health Matters. I see my good friend Karen Jackson here, Sister Zeke, and really support those groups and help them educate at a community level. So my goal is really, I work with patient advocacy organizations broadly. I work with the pharmaceutical biotech industry as well as professional societies. And my whole goal is to help them recognize the need to engage at a community level. And what you're doing right now needs to shift to be much more inclusive of a community.
Right.
So that's Links to Equity. And then I also represent Rare Disease Diversity Coalition, which I'm very proud of. It sits under the umbrella of Black Women's Health Imperative. And what we do is we focus on rare diseases, but more importantly, those rare diseases that impact diverse communities. So when you think about having a rare disease, I don't know if anyone in our audience has a rare disease, but it's very similar to having a health inequity just in being a rare disease. So just imagine how complex and complicated a rare disease is when you couple that with a diverse community and the health inequities associated with diverse communities under a rare disease sort of banner. So at Rare Disease Diversity Coalition, we look across rare diseases, including the kidney diseases that you just mentioned. And what we do is we work on 5 work groups. It's very multi-stakeholders. So we bring in researchers, we bring in patient advocacy organizations, professional societies, industry partners, researchers, and we really try to identify evidence-based solutions that support the challenges and hurdles associated with rare diseases and diverse communities. So taking all that, coupling all that, I just want to say the 5 work groups that we really look at, because we feel they're key challenges, is that of delayed diagnosis. We know that in our communities, we have a delay in diagnosis, and you touched on that. And as you try to examine your patients, we also know that there is a lack of diversity in clinical trials. We need to have trusted partners that we work with to help educate us on clinical trials, because clinical trials can be a very good thing. And I think that there's a lot of misconceptions about clinical trials. So having those trusted partners that we can have a real frank conversation with. Also, we look at provider education and helping them gain the tools that they need so that they're not having bias, or they're at least recognizing that there can be some conscious or unconscious bias in the treatment of patients. We also look at policy areas where we try to work at a legislative and a congressional perspective to look at policies that impact rare patients in diverse communities. And then finally, we look at I said delay in diagnosis, patient and caregivers. So that's the heart of what we do. When we look at the patient gaps, the caregiver gaps, and we try to understand how other advocacy organizations can help support patients and caregivers, but also what are those gaps? So we do a better job of helping them address their rare disease from these diverse communities.
That's a lot of work, but it's really important work, because one of the things that we have going on right here in California right now is a vote on something with dialysis that has been going on forever, which will directly impact our community. So one of the things that your organizations seem to do is to get the community engaged in this process. And so that's why the policy side is so important to me, because we as a collective can impact that policy if we know what's going on. If you know the clinical side that I deal with every day by asking your doctor, having your doctor talk to you, but also understanding what resources are in the community to actually advocate for you. And that's something we don't do in the Black community very well, is have a collective to advocate for the individual patient. So we need to partner with Black Health Matters and all these other groups to make sure that the community understands their role in pushing for certain things to happen at the policy level. That means vote. That means look up what your representatives actually feel about healthcare. That's an area that we just don't look at. I'm very happy to hear that you guys are doing this important work. It's fascinating to me as a public health practitioner before.
Thank you so much. And I got the signal that we're going to go on to Q&A, but I'd just like to finalize that and say that at a policy level, we also need to pay attention to the regulations that come out every year, whether it's at a federal level, a state level, or a commercial payer, and understand how that impacts our health. So I'll pause.
Dr. Jim Black again.
Jim Black.
In my dental practice, sir, I have a lot of patients who speak about kidney stones and gout.
I'm sorry, can you stop 1 second? Shh. Ask the question again.
My question, doctor, is could you please give us some information about kidney stones and gout? It seems to me in my practice, many people come in and complain about gout. Could you address that, please?
Sure. So gout is something that is caused by a change in uric acid at the joint level. Your uric acid level does not necessarily have to be elevated in your bloodstream, but there's something that takes place right at the joint level that causes people to have flare, and it has to do with how you metabolize gout. Now, the other question in regards to kidney stones is really important, and that's directly in my area of expertise. You can have uric acid kidney stones when you have too much uric acid floating around or not metabolizing it right. The most common cause of kidney stones is calcium oxalate kidney stones. Oxalate gets produced when you have gut problems with digestion, problems with how we actually eliminate. And so a lot of times people will have weight loss surgery, or they'll have a colectomy, meaning they get part of their colons cut out, or some of their small intestines is not working. That causes an increase in oxalate, which then calcium oxalate gets together. Now, the way to guard against that is to have citrate on board, which blocks the combination between calcium and oxalate. And everybody's heard about Crystal Light, I'm sure, except for the real young ones. Okay, Crystal Light has more citrate in it than even orange juice, okay? So I have my patients drinking a little bit of extra Crystal Light to get their citrate up. and drinking enough fluid. We don't do that in temperate climates.
Yes, that's what I wanted to ask you about. Can you tell us about the importance of water and hydration?
Absolutely. Hydration is extremely important, and you touched on it, that water, drinking plenty of water is really important. Your body is made up of 60% water. Why do you drink all this other junk, right? So it's also the type of water that you drink, because a lot of water, or some waters, have actually minerals in it, the calcium that I'm talking about. And if you have an increased oxalate problem and you have calcium there, and you increase your calcium intake, that's going to change how your bones react, how your brain reacts, and how your kidney is going to react to retaining that calcium. And so therefore, you will get the calcium oxalate that way.
Thank you. Your question, ma'am, what's your name?
My name is Dr. Kathleen Watkins, and I want to thank both of you for being here today, because kidney disease is at an all-time high in the Black community. And so my question is, could you talk about the 3 stages, or the stages of kidney disease, please?
Sure. There are actually 5 stages of kidney disease, okay? All right, so normal glomerular filtration rate, or function of the kidney, is rated by doctors as 90 or above. And then there are different categories between that, all the way down to 15, that tell you stage 1, 2, 3, 4, and 5. The reason that's important, I'm glad the question got brought up, is you usually go to your primary doctor without any inkling that you may have any kidney disease. Because in the primary care world, they're taught, unless your kidney function goes below 60, you really don't have kidney disease. That's not true. That's not true. We have data all the way back to 1998 and 2000 that actually say if a person sees a nephrologist once, they slow the progression of that disease. Well, that kind of got missed on our community because there are very few African American kidney specialists out there. So I always say that nephrologists are terrible marketers. So I'm glad you know that. But we don't talk about it in the nephrology world like people talk about diabetes in the endocrinology world. And I'm one who's going to talk about it.
All right, well, one last question. What's your name?
Hi, my name is Chanel. I'm from Long Beach. I have stage 4 chronic kidney disease.
You have what?
Stage 4 chronic kidney disease,
Okay,
and I'm
right.
on dialysis. But one of the things that I wasn't aware about, my doctor at the time didn't know, then I got a specialist and things were good. My question is, can you explain how some of the medications for diabetes and hypertension can cause problems that affect your kidneys that could cause you to have an acute attack of?
I'm glad you brought that up too.
Good question. Good question.
Because I tell people it's a physiologic misnomer, okay? When you have, let's take metformin, which is a very common drug for diabetes, okay? Metformin itself does not directly cause kidney disease, okay? What metformin does is, if you have a little bit of kidney failure or kidney injury or kidney insufficiency is the best word, then at a certain level, the metformin is more likely to cause muscle breakdown. When your muscles break down, all of those toxins that come from muscle breakdown go to the kidney to be metabolized, but they get stuck. Lots more happens, y'all, but just they get stuck in there. And so they stop the urine from being produced, which causes kidney function to be even worse. That's something we call rhabdomyolysis, okay? Muscle breakdown causing a kidney failure. One of the blood pressure classes that I am wary of in my African American patients is the ACE inhibitor class. ACE inhibitors are very good drugs. They help us with protecting the kidney when there's protein coming out in the urine. They help us with all kinds of stuff. But we have to be careful because more African Americans have allergic reaction to that class than other populations. And so when I give that drug class to one of my patients, because it's a very good drug, we have to be very careful in terms of how we raise that. Now, what that class of medicines does, real quick, what that class of medicines does is actually changes the physiology of the kidney. So it makes it look like the kidney is being more impacted. But because of the physiologic change of how the blood flows across the kidney, it does that naturally to stop protein from coming out, to stop all these other ills from happening, and actually protects that filter that I was talking about. So no, lisinopril, enalapril, captopril, all of those prils don't cause kidney disease directly, but they can impact the way the function looks. And if you go too far, absolutely, that can cause a dehydration right at the kidney level.
That was an excellent answer. Give them some love on all the answers. The Q&A, give them a round of applause all the way around for what they did this afternoon. Show your love. Thank you, guys.